Well, hello, this is Steve Reams with Ada County Medical Society, and I'm here today for our next 60 for 60 spotlight of ACMS member physicians. Today, I have the pleasure of talking with Dr. Sarai Ambert-Pompey. She's an internal medicine physician at the Boise VA Medical Center. She's also a faculty member of the University of Washington, Boise Internal Medicine Residency program, where she also completed her residency. So, Dr. Ambert-Pompey, welcome to our 60 for 60 spotlight.
Thank you for having me.
You betcha. Well, you have been at the Boise VA campus in the middle of this crazy springtime coronavirus crisis, and I'm just curious to start, how have things been going there at the Boise VA, and what has it been like for you?
Yeah, that's a big, large question. At least for our department in the Clinical Resource Hub, we try to make as many providers do telework as possible. So there would be less exposure from them coming to campus. So we were able to work on that and be very successful. On my medical education lens, I was able to provide faculty development so the faculty could help precept residents that were doing more telehealth because of the change in the with the coronavirus crisis.
I see, very good. So let's go back a little ways and talk about where you received your medical education. You received your MD at Ponce Health Sciences University in Puerto Rico, where you grew up. What was it like in terms of growing up in Puerto Rico, in terms of how you decided to get involved in healthcare, and maybe even what are some of the nuances that you've seen culturally between the way you were taught perhaps in Puerto Rico versus the way you've been involved in education in mainland US?
Yeah, it's definitely been different. One of the things that in Puerto Rico that really inspired me to go into medicine was that there was the poverty line is very big, and there's a lot of people that don't reach out to healthcare in general, and you know, it's with all of this going on and the lack of enough physicians in the island. My original goal was to stay, but unfortunately there wasn't enough residency positions. So I was forced to go, like many of my peers that graduated from medical school there, to go into the United States mainland so we can get residencies. And once we're there, with all the change, I travel so far, moving is not fun. So, and we
Right.
enjoyed Boise so much, and the, the vast community and all these things that are very similar, and we have access to foods that are very similar to Puerto Rican food. So it made it an easy transition in that way.
Great. So you came to Boise to come and finish your residency. You went on from there, practice
Well,
in.
well, I did 2 years in Portland in a clinical research fellowship. That was the first move that we
Very good.
did. And in Portland, there was a community, a small Puerto Rican community. In fact, I got a mentor there, Dr. Nemeshek, who's the head of the pediatric bone marrow transplant unit. And she was really, really helpful to me to see Puerto Rican women in a leadership position there. And it was very, I can do it too.
Right.
And
So the role of mentors in your life, not only in the receiving end, but now that you're in a faculty and a teaching role, what's the importance of mentorship, do you think, in not just your medical career, but in medical education in general?
Yeah, it's very, very important. I think that it helps to have that perspective where you might have, someone, a soundboard, to really bounce off ideas of, is this really going to move my passion forward? Is this going to move my goals forward? And have someone that can help you walk through that process, that knows already who are the right people that can help you with those ideas, and kind of help save a safe space, but also at the same time they can help guide you, like maybe you shouldn't go that
Yeah.
direction. That's something that doesn't sound like it really goes with what you want to do in
Yeah.
your long-term goals. So it's very helpful.
Yeah, I mean, because there's so many minefields as you're learning medicine, as you practice medicine. It's nice to have somebody steer you around those things if
Yeah.
at all possible.
And
Well,
also
go
it
ahead.
helps that they know what your skills are, and they like, well, this and you kind of match well with your skill
Mhm.
set and your goals, so this probably is a better road for you than this. And and to have that, you know, sometimes might be shocking to hear, like, oh, but then it makes sense when you think about
Yeah. Now, at OHSU, you completed your fellowship in neuro-oncology. As you moved into internal medicine at the VA, what kind of ways have you been able to apply that, or what kind of novel things are you seeing even in that field?
it. Yeah, so one of the wonderful things about the neuro-oncology department is that it's very translational oriented. So we had we had a research part of the department that was doing like testing on rats and these novel things that we're doing. And then we also had research that was clinical on patients that had a lot of orphan disease, which is, you know, diseases that doesn't have a large number of people having them per
Mm-hmm.
year.
Mm-hmm.
And we were able to do research on the imaging, on the treatment, on the neuropsychological impact of both of those things on the
Mm-hmm.
patient. And the patients were so open to help and leave some sort of footprint to help
Yeah.
the next person.
Yeah.
And it was just a wonderful experience. And having those meetings every week where we talked about the innovations, the research, it was just so inspiring that moving forward, it really helped me when I started being a mentor for quality improvement projects. It really helped that mentality of figuring out what's the next step on the project, what kind of things we can
Yeah.
change, and just have that innovation mindset.
Yeah. And that's great. And you work in a very innovative field. We've talked, actually, we had you as our instructor for our recent telehealth webinar. You've been involved in the Vision 20 Northwest project in TelePrimary Care for the past 5 years, telemedicine, developing the local TelePreceptoring program. Let's talk about innovation and even in current landscape. How do you see things changing? What things are working? What things are not working that need to be fixed in the realm of telemedicine?
Yeah, wow, that's a loaded question.
That's a lot of
Um,
questions.
but I love it. I love it. These are very important questions. So I feel that over the year, the technology has not changed as much. It has been there, maybe gotten a little better. Bandwidth has been easier to get, perhaps. Um, I think that one of the things, there's research that shows that the biggest barrier before COVID-19 for people doing telehealth was the lack of training.
Mm,
So now that they were with COVID-19 forced to incorporate telemedicine into a lot of practices,
mhm.
they didn't really get a chance to get training, get comfortable. It was just sink or swim. Here you go, good luck. And that can be scary and not comfortable, and maybe people might resent that. But um, it's important that education for telehealth moves forward. There's a lot of best practices out there. There's a lot of things that can improve it. One of the things that has changed this year with COVID-19 is the reimbursements, and that was very important. And it's important that some of those, if not all, continue moving forward, because
Absolutely.
it has
Yeah.
proved that telehealth it can be an important part of a practice. And it's not an end-all kind of tool. It's
Right.
just another tool for the toolbox, just providing an option for your patients that they don't have to miss a day at work to see their provider. They don't have to travel 2 hours, drive around the parking lot to find a spot, to
Especially the VA parking lot, right? Because we've all had that experience.
get all flustered and then get their blood pressure measured,
Yeah,
which
there you
goes
go.
really well. So getting those barriers out of the way and providing another option for patients is very helpful. So that continue forward. The yeah, the ACGME was already in the plans of changing how they were going to let the supervision for telehealth be done for indirect supervision of telehealth. That was going to happen on July 1st anyway,
Okay.
because they recognized that it's important to train in telehealth. However, they approved that in March as soon as the crisis was called, just to move forward out
Okay.
of need.
Yeah.
So those things, you know, the education, putting the policies that go with those are important. For example, the anywhere to anywhere law for the VA had
Right.
excellent language for its provider, but it didn't have language for the trainees. And
Oh.
so if we have trainees doing telehealth to home across state line, we have to be on that video call. So it's something that is not going to add anything other than we're just out of legally we have to do it. And then so when future policy and for any state, obviously for Idaho, my hope is that they take trainees into account when they do those policies.
Yeah.
So we can continue to provide updated medical education.
Yeah, and this is the difficulty, of course, with just a different fabric of state-by-state policies on Medicare, Medicaid reimbursement, and all those types of things that we run into. Yeah. So when you think about lessons that trainees and residents can take away from such an extraordinary, rapidly changing time like this, I mean, healthcare was already moving very rapidly before, but what are your thoughts in terms of how residents that are graduating this year and the next couple of years, the new landscape that they're entering into is going to be really different. What do you see the challenges and the opportunities are going to be for them?
Yeah, I think that if we have learned anything from this situation is that we have to be flexible and we have to adapt, and we have to remember that in the end we have to remember the patient.
Mm-hmm.
Reaching out to the patients that don't reach out to us as much. So I think that continue to provide that patient-centered medical home models that have integrated telehealth. It's something that needs to be done out of necessity at this point, but also it's important that we take into account that there's going to be challenges, because it's not without it. You have to invest in technology. You have to train people to use it. You have to keep it updated, and then you have to make sure your staff knows how to use it, and the workflow of the clinic. And it's a lot of different tiny components that have to be taken into account. And my hope with the education piece is that they learn to be agents of change wherever they end up, and that they can to the very least have the basic telehealth skills to move forward with it.
Yeah, and this is a lot like over the past 20 years in terms of the adoption of EHR. This is upon us. There's probably no going backward, at least not very far. And so how to integrate this into the clinical workflow is going to be a really important thing. And I think that the exciting thing is that patients want this. And I think clinicians, by and large, are beginning to see the advantage of this. So it may not be as painful as the EHR adoption perhaps has been. But
yeah, I think that's a great analogy, because EHR, we talked a lot about meaningful use, and the same thing should be used with telehealth.
Yeah.
It should be used meaningfully. It shouldn't be used just for the sake of using it, but at the same time, having that additional dimension of seeing the patient and having that social connection and the rapport can mean a lot to a patient.
Yeah.
It can even be therapeutic.
Yeah, and so talk about that. What do you mean by that exactly?
Well, sometimes when you are talking to a patient through the video, as opposed to a telephone call, you see them that within a few minutes, that rapport and that relationship is there, and they're leaning forward, they're engaged, and their behavioral cues, you can see that there's an engagement. And if you say something that they might not understand, you kind of might see their face and, okay, I need to spend a little more time on this. And it's very helpful. You wouldn't get that with just a phone call.
Well, for sure, without a phone call. Yeah, and the challenge, of course, with physicians is, do I look at the camera? Do I look at the screen? How much time do I spend between both? And, you know, those types of behavioral cues that are like maybe not obvious at first, but then you begin to learn to do them.
And it makes a difference to the patients.
Absolutely, yeah.
They feel like they're connected with their provider, with their physician, and it makes a difference to them.
I'm glad that you bring this back around to the physician-patient relationship, because that's really at the core of why anybody goes into medicine. And so can you think of a time where you've developed a relationship with a patient that really solidified for you why you went into medicine in the first place?
Oh my goodness. I get a lot of those all the time. Even this week, I had a patient who was really struggling with mental health given all this that was going on. And when they, we were able to finish the visit, and I wasn't sure whether it was useful or not.
Yeah.
And they reassure you, like, I think this visit was better than any pill. And
Wow.
you get really like, oh, really? Not expecting that kind of response to that visit. It just makes it really, really satisfying and very like this is what I'm meant to do.
Exactly. When you think about the kind of the values, or maybe the perspective that you hold very dear to you in terms of healthcare provision, medical provision, and you say, I wish this could get replicated across the Ada County Medical Society community, what kind of things do you wish you could take from yourself and just give out to everybody, and that would be incorporated in their healthcare practices and medical practices?
Do you mean like a quality, or you mean more like a skill, or
If you were queen for a day,
for a day?
what would you want to imbue in the culture of medicine locally that maybe doesn't exist right now?
Gosh, I think we need to do a better job of putting the patient first. Sometimes I hear people call, oh, this diabetic, but we need to remember that's a person with diabetes. And putting the patient first is important. Not that, oh, they're not compliant. No, we're not. This is not a dictatorship. It's a partnership. Can they adhere to the plan? That maybe we're not making the right plan for this person. And maybe our goal should be different.
Yeah.
Because there's the guidelines recommendation, but a guideline guides, and each patient is different and their circumstances is different. We don't know if they have, history of trauma or something else
Right.
that's getting in the way of them being able to do all the behavioral changes necessary for a particular chronic disease process. So
Yes.
I think that we need to do that more.
Seeing the patient as a person, not as a disease inside of a person.
Exactly.
Yeah, we could all do better there, couldn't we? Well, I always like to end by asking, outside of healthcare, what do you like to do to restore and refresh yourself?
Oh my God. All right. I am an avid music concert goer, which has been on hold for now.
Yeah, unfortunately.
Yes. So I'm looking forward to future ones. I see these dream ones, not the same, but still useful. But connecting virtually, socially with that group of friends is helpful. Connecting virtually with family, friends is always good.
Yeah.
And going outside every now and then is always useful too.
Every now and then. We could all use more of that right now.
Well, it's raining today, so.
Yes, it is raining quite hard. So, well, we appreciate your time, Dr. Sarai Ambert-Pompey. Thanks, and we're glad to have the spotlight on you for this moment, and appreciate the medical care and attention you give to your patients and community.